I got a question for you. What do you do for that patient that has refractory hypoxemia? Are you just cranking up the PEEP? Are you recruiting them? Or are you proning them? Well, today I had the pleasure of speaking to Zentensivist Shoo-Bah from the Cleveland Clinic, who's going to give us his approach to the refractory hypoxemic patient. And this video, it's jam-packed with tons of great information. So before we go on, why don't you go ahead and hit that like button. And if you want to check out more of our content, go ahead and hit that subscribe bell so you never miss anything. So without any more delay, let's cue the music.
So my name is Shoo-Bah. I'm a medical intensivist at the Cleveland Clinic in Ohio. My main interests are sort of general critical care, but particularly ARDS, shock, RV dysfunction, and ultrasound.
Like just a couple things, right? This guy is a monster on social media. He's always putting up really good cases and vent waveforms and really pushing the boundaries of what we do with FOAMed right now. So I'm really psyched to have you on and talk about, you got a case that we're going to talk through?
Yeah, thanks. So we'll start off with a case. This is a 26-year-old woman who is 3 days postpartum after a C-section, and she's developing progressive hypoxemia in the setting of frequent vomiting. They call you up to the OB floor to see her as her oxygen requirement's gone up from 2 to 6 liters, and now she's on a non-rebreather, and that's happened just over 12 hours. You're admittedly worried about this patient, so you move her to the ICU. You place her on high-flow nasal cannula, and she's requiring 80% oxygen in order to maintain saturations of 90%. Her blood pressure is 110/70. Her heart rate's 124. Her respiratory rate is 28. You're a little bit concerned. Her level of consciousness is kind of fluctuating in and out a little bit. Like I mentioned, she's breathing 28 times a minute. The respiratory therapist comes by and gets a blood gas for you, and she's 746 pH with a PaCO2 of 24 and a PaO2 of 75.
So any medical problems with this lady? Is this...
She has a stage 3 obesity, but otherwise was an otherwise healthy woman.
And 3 days postpartum, anything with the pregnancy, anything strange or out of the ordinary?
Nope.
Huh. All right. So, I mean, at this point, what are you doing when you walk in the room? Maybe you got called as a consult, I presume. Yeah.
So when I'm going to see this patient, the history is concerning for somebody that maybe has had some aspiration going on because she's had some frequent vomiting. I'm not sure why the vomiting is going on. But now we have this added layer of somebody who's in the immediate postpartum period and could have any myriad of postpartum complications, whether it be pulmonary embolism or postpartum cardiomyopathy or other things that could lead to respiratory distress and respiratory failure. So kind of my mind is kind of churning through the differential right now, trying not to hone in too much on the what seems the obvious piece, because this is a person who could have hypoxemic respiratory failure for many reasons.
Right. So for someone like this, what's your first intervention while you're trying to figure out what's going on?
So I kind of already thinking about it as we laid out the case, is putting this person on a high flow nasal cannula, at least to give a little bit more oxygen support, perhaps a little bit of positive pressure with that, at some low level, while sort of the dust is settling to just sort of do ABC's type of management right now. My next thoughts are really focused on trajectory, because now I have somebody who's got rapidly worsening hypoxemia, who's in the ICU and still not thriving terribly well on high flow nasal cannula. So I'm anticipating this is someone who's probably going to need higher level of support than what we're giving her at this moment.
Gotcha. And at what point do you decide to put her on non-invasive, just to abandon the high flow?
Great question. So I think in a case where the cause of hypoxemia is undifferentiated, I'm not quite sure what the exact insult was that led to this. My personal practice is to be a little bit hesitant with non-invasive positive pressure and a de novo hypoxemic respiratory failure. The data is sort of wishy-washy on whether this is a good thing, and certainly there's a signal towards potential harm as the degree of hypoxemia increases. Another thing that I'd be worried about in this patient is she's been vomiting pretty frequently, and that's sort of at least a relative contraindication of non-invasive positive pressure.
Gotcha. Could you speak about to why non-invasive would be not such a great idea, besides the vomiting issue, when you speak about the literature on that?
Sure. So Admittedly, most of the data on this is observational and retrospective in nature, but there's a good amount of data that suggests if your PaO2 to FiO2 ratio is less than 150 and you have something that looks like it could be a ARDS or a hypoxemic respiratory failure, your mortality may be higher. And there's some good rationale why this could be true. If you think about the kind of things that we try to do to people when they have ARDS on the ventilator, we're trying to maintain low tidal volumes. We're trying to have very precise control of airway pressures, certain level of PEEP, and we have a sort of continuous seal that gives us a fairly reliable mean airway pressure. And kind of all that goes out the window when you put somebody on non-invasive positive pressure. I suppose you could watch them closely to see if they can improve quickly over an hour or two. But my concern would be that this is somebody who then gets put on non-invasive and then maybe acute lung injury or ARDS is precipitated by being on positive pressure with injurious tidal volumes over time. So I wouldn't say it's a hard no, but I'd say you'd really have to think carefully about what's your endpoint with that and how long are you going to let that go on for.
Gotcha. Do you ever feel that people, part of the harm comes from the fact that people put them on non-invasive and then they take a mental break, or they just say, well, at least we have this, and now you're delaying care that ultimately that patient's heading towards based on your clinical gestalt?
Yeah, absolutely. I think there's a, non-invasive is something that lulls people into a false sense of security a lot of the time. It's like, I didn't have to intubate them, so I feel better about my job. But if you're prolonging the time to the definitive intervention that's necessary, then that's probably a bad thing. That being said, it's sometimes hard to tell where their trajectory is going to plateau, and that's why I think some people will get into the habit of starting with non-invasive more often. And again, there's nothing I can say to say that's definitively the wrong thing to do, but I would exercise caution in that, and certainly not walk away from that patient for the next hour or two.
That certainly makes a lot of sense. If you're going to do it, careful eye. And I always tell people, anytime you put someone on a non-invasive ventilation, just whether it's a hypercarbic failure or a hypoxemic issue, you have to have some expiration date for that person.
Right.
It's like you look at that person, and it's different for different people, but I'm going to give that person 45 minutes. And if I do everything aggressively and I watch that person for 45 minutes and they still look terrible, well, then I know it's time to intubate, even if they look like they're not crashing.
Right.
But I've given that person their fair shot at non-invasive.
Absolutely.
Yeah. Okay. So what happened to this patient? What was going on? Or I mean, what were the next steps for you?
Sure. So the thinking about that differential diagnosis list that we came up with initially, thinking about aspiration or postpartum cardiomyopathy, or perhaps a pulmonary embolism as a cause of respiratory failure. The next step for me, whenever I have a patient with undifferentiated respiratory failure, is to grab the ultrasound machine.
Mm-hmm.
So that's what we did in this case. So we pull over the portable ultrasound machine, and we do a quick heart and lung exam.
Mm-hmm.
And we're not necessarily trying to do terribly advanced maneuvers here, but just kind of get a global idea of what might be going on. We have a history that kind of sounds like aspiration pneumonitis, but we need to do our due diligence here and do a little bit more of a search. Sure. One thing that I'll mention, since we're going to put the probe on the chest, if you have somebody that has severe hypoxemic respiratory failure, particularly if you look at their heart and their RV looks dilated, it's probably reasonable to at least think about whether there's an intracardiac shunt as part of the issue. And that's something that we can screen for with just a bedside bubble study. And that's something that we do not infrequently if we get into one of these situations where it seems like the hypoxemia is worse than what the patient looks like. So in this case, we bring the ultrasound over to the patient, quick probe on the chest, looking at just the main, 4 cardinal cardiac views. Her LVEF looks normal. Her RV is a little bit dilated. The function might be down a little bit. So as a result of that, you go with the bubble study. The bubble study is negative. You don't see any bubbles crossing over the intraatrial septum or even later than that. So then you move to the pulmonary exam. And what you see is a pretty classic pattern of patchy B lines, which are asymmetric, and the pleural line looks irregular in some cases. So this is really starting to point more towards a non-cardiogenic pulmonary edema, like ARDS, secondary to aspiration.
Gotcha. So at this point, does she look like a candidate for some form of non-invasive, or she's already failed the high flow and it's time to intubate?
Yeah, so I think what pushed us over the edge in this case was the fact that her mentation was fluctuating, and it seemed like it wasn't necessarily rebounding in a good way with a higher level of support from the high flow nasal cannula. So this patient did end up getting intubated and was placed on invasive mechanical ventilation.
Gotcha. And, one term that sometimes will come up, and it's a poorly defined term, I'll let you talk more about, is refractory hypoxemic respiratory failure. Like when is that definition deemed that they're refractory, or what are some hard rules? Anything that you can speak on?
Yeah, that's a great point. I wish we had a uniform definition for this, because at this point we really don't. There's a couple of different definitions that float around in the literature. A couple examples would be if your PaO2 is less than 60 on 100% FiO2, that would be somebody that has hypoxemic respiratory failure, or somebody that has a PaO2 to FiO2 ratio of less than 100 on positive pressure. That would be another sort of a warning sign. Different studies use different thresholds. As I'm thinking, and so as a result, there's no uniform definition. Maybe someday we'll have one. The things that I think about when I'm considering if somebody is in that sort of potentially refractory box is if they're requiring more than 60% FiO2, that is a place where I start to wonder if this person has at least let's say, insufficiently treated hypoxemic respiratory failure, if not refractory. And then if it's somebody that's already ventilated, things that make me think about refractory hypoxemia are people who have unsafe vent pressures and still have difficulty oxygenating. So you have somebody who has an unsafe plateau pressure, something above 30, and you still can't oxygenate them appropriately. Then I'm starting to think this is a person who's in a situation of refractory hypoxemia, and they need a more advanced eye to look them over.
Gotcha. So it's really a relative definition. If you're not intubated, maybe more of an FiO2 and a saturation issue. If you're intubated, whenever you're in a situation where you've done your best practice, and we can maybe call that standard care, although standards will differ amongst practitioners, but you have a plateau pressure that's elevated, your driving pressure is high, and you've done your usual things, at that point you would call it refractory.
Yes.
Okay. So what happened after you intubated her? Did she land up in this refractory category for you?
Yeah. So the way that she started off is she's intubated. She's placed on appropriate tidal volume settings. So she's on 6 ml per kg of ideal body weight with a respiratory rate of 24. Her initial PEEP was set at 10, and her plateau was 28. With these settings, her SpO2 was still about 87 to 88%. So it still seemed like there was some room for improvement. So here's the point where we start talking about how do we optimize the settings on this person. If you're somebody who is going to intubate a patient and place them on some level of PEEP until they get transferred somewhere else, then I think probably the safest thing is just to follow the ARDS, the ArdsNet low PEEP table. So this person with a FiO2 of 100% would end up somewhere around 16 or 18 a PEEP. Bearing in mind that you really still have to keep an eye on your airway pressures to make sure they're still safe. So this person on a PEEP of 10 had a plateau of 18, so the driving pressure is 18 in that case. With some sort of incremental rising of the PEEP level in this patient and reassessing the driving pressure and the plateau pressure itself, we eventually ended up at a PEEP of 18, and her plateau was 28 at that time. So the driving pressure was only 10, despite the fact her plateau never changed. So that suggests that there was some recruitment that happened. Some alveoli opened up, some airway pressures came down as a result of that. And she was able to be weaned to 40% FiO2 as a result of that. So this patient actually responded quite well to PEEP in this case, but we can talk about what happens when people don't respond subsequently.
For sure. And just to make sure that everyone's on the same page, could you talk a little bit about driving pressure, what it is, and the data behind it?
Sure. So this is another piece of the puzzle that is really supported mostly by observational data. A driving pressure, as we've alluded to, is the plateau pressure minus the PEEP. And this is really a reflection of the compliance of the respiratory system, because you're basically saying this is the amount of inspiratory pressure I need to generate this tidal volume. So obviously a higher driving pressure for the same tidal volume means your compliance is worse. In the seminal study on this, which was done by Marcelo Amato in 2015, a driving pressure of 15 or above was associated with a higher mortality rate. The really interesting thing about that study was really kind of subsequent to that number. There's in figure 2, they look at what happened to, as PEEP changed, what happened to the driving pressure and how did that affect mortality. So if you increased your PEEP and your plateau rose in a stepwise fashion, you got no benefit from it one way or another, that, no change in mortality. if you increase the driving pressure and your plateau pressure rose disproportionately, or your driving pressure was increasing during that time, your mortality was actually higher. And then finally, most interestingly, if you increased your PEEP and your driving pressure decreased, that was associated with lower mortality. So there's a suggestion here that there could be an interventional benefit to trying to shoot for a low driving pressure, and low probably would be less than 13 to 15 in this case, in order to try to scale the delivered pressure to the size of the lung that you have that's actually participating in gas exchange. One way to do that is to adjust the PEEP, as we've alluded to. Another way to improve driving pressure is just to lower the tidal volume. But that comes with its own sort of limitations in terms of you're going to have a lower minute ventilation. You may have to have a higher respiratory rate, and that could make ventilation a little bit more challenging. And ventilation this way, I'm talking about CO2 removal.
Right. And so for you, when you go up to the bedside, and let's just take a real world example, or this patient, you go up to the bedside, let's say that the plateau pressure is, let's just say it's normal, or you're okay with it, and you do your driving pressure. Do you still, but they're still hypoxemic, do you still try and increase your PEEP? And then what are your steps that you go through? What are you watching? Just let's get your stepwise approach of how you do that.
Sure. So generally I will, if the most common scenario that I run into, especially when we receive patients and transfer from other facilities or from the emergency department, is the PEEP is often set fairly low. I think there's a good amount of hesitancy around using even the low PEEP table for people with ARDS amongst practitioners across the country, certainly. And I think that's borne out by a lot of observational data. So the first thing I usually do is try to get the get the PEEP in a range that's somewhat similar to the ArdsNet table, and get an idea where the driving pressure is around there. So if somebody's on, 80 to 100% FiO2, I'm in the 16 to, 20-ish range for PEEP. The important thing to think about at that point is how long do I sit on this setting before I reassess the driving pressure? Because you'd think if I raise the PEEP, I would hope that some alveoli would open, and it's hard to tell how long that would take. There is data to say that probably between 1 and 5 minutes is enough time for you to see that change. So that means if I'm making several changes, I'm probably at the bedside for 20 minutes or so, trying to see how this plays out. And I really do try to follow the guidance from the Amato paper there to say that if I'm increasing my PEEP and my plateau is, and my driving pressure is not changing, I'm not sure that I'm doing any benefit. So then I usually will not keep going up at that point. But if every time I go up, I get a little bit of a decrement in the driving pressure, then I think I'm probably recruiting in one way or another, and being helpful. The catch about raising the PEEP and not changing the driving pressure is you don't necessarily realize that you may be over distending this person because the airway pressures aren't becoming unsafe. But what you may be doing is distending the alveoli enough that the capillaries that head to those alveoli are getting sort of smushed down and not participating in gas exchange, and you can actually make your hypoxemia worse. So it's really something that has to be done fairly delicately in that way.
Got you. Do you ever do recruitment maneuvers, just the usual 30 over 30 or 40 over 40, or is this your go-to move now and it's replaced that?
So it's usually a hybrid of those two things, and it depends on sort of their X-ray and how, if they look like maybe there's a significant component of atelectasis, then I might do a recruitment maneuver, or if they have significant obesity, I might do a recruitment maneuver. And as you mentioned, I do tend to favor kind of like the 30 for 30 approach. So, a PEEP of 30 with no inspiratory pressure for 30 seconds. This has also become controversial over the last few years because there's a couple of larger studies like the ART trial that came out that suggested that recruitment maneuvers were harmful. But man, those are very aggressive recruitment maneuvers at an inspiratory pressure of 45 for like 2 minutes. Things that I have never done or even thought about doing in my life. So I don't go quite that aggressive, but a 30 for 30 is not an uncommon scenario for me. In those cases, I'm keeping a very close eye on my O2 saturation and my blood pressure, because it's very easy to over distend a person in those cases, especially if they weren't all that recruitable to begin with. So it's nice when you have an arterial line. I wouldn't say it's a requirement, but certainly you want to see these changes fairly quickly. So the three things that I would have in my, that I would be monitoring closely at this time would be the pulse ox, the blood pressure, and if I don't have an art line, I'm cycling it probably every minute or every 2 minutes, and then also the end tidal, quantitative end tidal CO2, because that'll give you an idea too, as if you're over distending or not, because you might lose some of your signal from that.
Gotcha. And then just one more question on that before we go on with the case. For PEEP and a lady like this who you said she was morbidly obese, say class 3, where's your PEEP starting point? Just post intubation, the therapist says, what settings do you want?
Yeah, so this is it will admittedly be a little bit of voodoo for me to give you a number, but I'd say I'm usually, if it's very severe obesity, I'm usually in the 16 to 20 range to start. To give another example, I had another patient with ARDS physiology who was 700 pounds, and and came to me on a PEEP of 8 and was on 100% FiO2. And that gentleman ended up on 30 a PEEP by the time I was done titrating. And his plateau was technically unsafe at 38, but his driving pressure is 8. And you know, and you have to really keep in mind the contribution of the chest wall and the abdominal wall to the pressures that you're measuring in those cases. So do I know that driving pressure is the right thing for severe obesity patients? No, I don't, but it kind of jives with me, and it avoids the need to put down like an esophageal balloon or something, at least in my experience to this point.
Right. And it also gives you just that permission and shows the rest of the team, because the problem that I found is that I want to go up on the PEEP and the team is very uncertain of it. We don't have esophageal balloons, and you know, I wish I could show them at the bedside the physiology, but with driving pressure you can tell them, look, this is safe, and then you go through the abdominal component of it and the chest wall component, and they're a little bit more on board. But you know, it's starting 20 of PEEP would make any respiratory therapist and frankly some other practitioners very nervous about that.
Absolutely.
But to your point, you know, for these people, their alveoli are not seeing a PEEP of 20.
Right. Yeah. The other thing to keep in mind too, and I learned this from Augie Gadzik at Mayo Clinic, is they are very, very particular about body positioning of their morbidly obese patients to offload that abdominal component of the sort of transmural pressures. So what they'll often do is put somebody either in reverse Trendelenburg position or in a chair position, even if they're, you know, completely out, to kind of offload that component. You can lose easily, you know, 1.5 liters of your FRC in an obese person by laying them flat. So the body positioning becomes really important in those cases. Especially during intubation, you know, the tradition is to lay people flat or, paralyze them, then lay them flat. But there's a tremendous amount of de-recruitment, and then you'll have to work back to get that person, especially post-intubation, they tank their SATs. Absolutely. Those cases actually, what I've started doing in those cases, especially if you have somebody who's already, it's clear they've already passed the point in which they should have been intubated. You know, you have somebody that's on 100% non-invasive and they're satting 88%, is I often will intubate them in a 45-degree head-up position, which sometimes requires standing on the back of the bed and holding a glide scope over. And it's a little bit of a maneuver, but it avoids those critical desaturations that you're talking about.
Yeah, if people don't know you, they're going to think you're a maniac standing over the bed. When I first started this new job, I did a lot of upright intubations, and you know, the beds aren't set up for it, so you're doing a little bit of a balancing act. And they're like, who is that guy? But then you get everyone on board, you show them the data, and then people are like, okay.
Yeah, fortunately, everyone knows I'm crazy at this point, so now they're just used to it. So.
Maybe that's the key, just start off crazy.
Yes, exactly.
All right, so you said that this patient got better when you were titrating the driving pressures, keep an eye on your plateaus. But let me just throw a monkey wrench in this and say that the patient, severe ARDS, not getting better with your traditional maneuvers. What are the next steps on your algorithm here? Yeah,
that's a great point. I think now we're at the point where you have to start talking about rescue therapies, because we've already kind of maximized what we can do with the ventilator. The first thing and the most evidence-based thing to do next would be to utilize prone position ventilation, because this is somebody who obviously has a PDAF less than 150, and we've done what we can for the first, X number of hours to try to optimize their mechanical ventilation. It becomes difficult at a certain, body habitus size, and that's something that could be a limiting factor in this particular patient. But in general, it would be the right thing to do to move forward with that next. Most of our most of the lung involvement in ARDS ends up being sort of posterior basilar, which is the area that in the supine position has the richest blood supply, and then as a result is getting the worst gas exchange. So we kind of take that out of the equation when we flip someone over and put them face down, and also offload the mediastinum from those posterior basilar segments, and hopefully allow those to recruit up a little bit as well. So that's the most evidence-based thing to do. It's the only thing that has a mortality benefit out of the things that we'll talk about, with the possible exception of ECMO if you're a believer in Bayesian reanalysis of studies. So it's the right thing to do next, unless there's some limitation, whether it's a patient-specific factor or if it's an institution-specific factor. But if you can't prone them, you probably shouldn't talk about doing any of the other rescue factors, and they probably should move to another center.
Gotcha. That's a good point. If you can't prone, which is, I mean, I think some people wouldn't even call it rescue. I mean, I think
Right.
some people do, but some people say that's part of their standard care. But maybe in
Right.
a larger institution that has a good team, that has a protocol, they know what to do. They're like a well-oiled machine. Whereas others, it is a rescue maneuver because they don't do it, or they've done it a couple times and they don't
Right.
feel comfortable with it. So that's
Yeah, for us, it's a standard measurement or a standard practice. But yeah, in other places it may not be, and it may be something to do as a last ditch before you transfer to another facility.
great. All right. So what would be next then in your stepwise algorithm?
Sure. So the things that I'll talk about things that are potentials as next, and then we can talk about what would actually happen. So the things that people start to think about at this point is this a synchrony issue where I need to employ neuromuscular blockade? That's kind of the least aggressive of the possible choices that are left. And then other things would include alternative modes of ventilation like bilevel or APRV, and then finally pulmonary vasodilators. And that's all before we even get to talking about VV ECMO, which will be, sort of the last thing. To talk about the first three in turn, I think neuromuscular blockade is probably the most frequently used thing, and even more frequently than prone positioning in a lot of cases. Currently not supported in terms of benefit in terms of mortality. At this point in time, I think a lot of us are moving to the point where instead of doing continuous infusions, we're using intermittent doses as we need them to avoid the need to be continuously paralyzed and continuously deeply sedated, because that creates its own issues in terms of mobility and neuromuscular weakness and delirium and things like that. So that's a fairly easy first step that people often take when things are a little bit out of control. And it's not necessarily the wrong thing to do. It's just not, I wouldn't expect it to fix all the problems that are there.
Mm-hmm.
To talk about the other two, APRV or airway pressure release ventilation, there are believers and there are non-believers in this, and the evidence base is kind of weak. I am a non-believer, so my ability to speak about it eloquently is kind of limited. I don't know, is this something that you're using, Haney, or?
Yeah, I use it as a tool in the toolkit. I know there are people that use it for every single patient that presents, or anyone that has any sort of presentation of hypoxemia. I'm not that person. I like to do, proning. Well, first, everything that you said with the focus on driving pressure, recruitment, then we go to proning with paralysis. And then if I'm there where I'm still having trouble, then I absolutely will. I mean, I'll give them a trial of APRV until we call our ECMO team for sure.
And that seems reasonable to use it in a sort of a rescue fashion. It's within our institution, it's unfavorable, in terms of just the culture. So it's not something I've got a lot of experience with. I used it more when I was like at the resident level and things like that.
To your point, not to interrupt you, but your point is great, because you can't, if you're the single person that uses it, right, unless you're going to be there for 24 hours a day for the next, 14 days, the patient's going to be there, and there's going to be a change where someone's not familiar with it, it's definitely not the best mode of ventilation.
Right.
Everyone has to be on board. It was like the oscillator, for example.
Sure.
You could say the oscillator, the data was not very good. Other people would say it's like the swan. You don't use it anymore. People don't become experts in it.
Sure.
Therefore, that skill set has fallen off. But so I think the same thing is true of APRV. You really have to know what you're doing.
Yes.
Otherwise, you can cause harm, or at the very least, not move in the water.
Right. Absolutely. So that's a great point. And again, I could definitely see the rationale for using it. It's nice to consider being able to not have to paralyze somebody even though you have their main airway pressure super high. I just need, for myself, I need to see a little bit more data for it first. And then the last thing I'll talk about is pulmonary vasodilators. A lot of people use inhaled nitric. In our shop, we use inhaled epoprostenol, which is nebulized, which there's probably no significant difference between those two things. It's a little hard to say. The rationale here is to provide better perfusion to oxygenated segments of the lung. In every way, shape, or form this has ever been studied, it improves oxygenation and nothing else. So I certainly wouldn't use it before prone positioning because it might talk me out of doing a life-saving intervention. And I may or may not do it before ECMO, and it kind of depends on the circumstances of the patient. For me, as a fierce advocate of the right ventricle, the most likely time that I will reach for it is if I feel like core pulmonale is happening as a result of the ARDS, more to support the right ventricle than for oxygenation per se, just to try to reduce the PVR in any way that I can. That's something that I'm more likely to use it for than actually for the oxygenation issue itself.
That's great. Good point that, it gives you this false sense of security where you might delay the next logical step in your management. The numbers look better, the stats look better, never a mortality difference shown in it. So you're better off saving it for when you've done the things that have a mortality benefit, for the more aggressive measures to just get them over that hump for the number, because sometimes you do want to see the number better. You've done everything and you just want to see that number better before you cannulate them.
Sure.
Yep. Great. And then it sounds like the last stop in your armamentarium would be ECMO.
Yeah, absolutely. So that's the final frontier and salvage for hypoxemic respiratory failure, refractory hypoxemia. I think there are some important lessons that we've learned over the last handful of years from the Caesar trial and then from Eolia and then the Bayesian analysis, reanalysis of Eolia, which I think actually was probably helpful. I think there's probably a place for this. I think everyone's threshold to initiate extracorporeal life support for lung failure is different. For me, I think the things that would make me have that trigger would be, let's go back to our patient who we have proned and still we're not able to oxygenate appropriately, or our airway pressures are unsafe, or let's say they have a mixed deficit. One of the cases more recently in time that I was more interested in placing on VV ECMO was a lady who had pretty significant COPD as well as ARDS from a pneumonia that kind of came out of nowhere. And as a result, it was really, really difficult to provide CO2 removal to her with our typical sort of low tidal volume, high respiratory rate settings, just because she had so much air trapping that we just couldn't get any CO2 removed. So that to me would be like a prototypical patient that would be good to place on VV ECMO because they have a combined deficit and I really can't optimize it any other way. In the case of a really severe hypoxemia that's not responding to prone positioning and maybe inhaled pulmonary vasodilators, there's probably a role for it. Two other places that I think are really a little bit higher yield in this way is if you have a really horrid unilateral disease, like a necrotizing pneumonia taking out one lung nearly completely. That's going to take a while to get better, and if you provide higher vent pressures, you're just going to overdistend the good lung and not do much for the lung that's ill. So that's a good opportunity to do it. And then as a related note to that, anybody who has something that you think is going to take a long time to get better, but you're going to bridge them to recovery or bridge them to a lung transplant, then that makes a little bit more sense, because then you can perhaps have a patient that can be a little bit more awake, participating in their care a little bit, doing physical therapy and things like that. So if you're bridging them either to a transplant or to a prolonged recovery and they have severe hypoxemia, then that probably makes some sense.
Gotcha. That makes a lot of sense. That's great. So let's go back and summarize this patient, because you said that she was getting better. I lost track of where she was turning the corner. So
sure. So this was a patient. The reason I brought this case to bear is not only because I had an interesting differential diagnosis, but because also we have somebody who responded really well to more conservative therapies. We didn't have to, break out the entire toolbox. She was able to wean down to 40% FiO2. Then At that point, when we're sort of out of the refractory box and we start to focus on more core interventions that are really high yield for patients, starting to interrupt sedation and allow this person to be awake as much as possible, doing breathing trials within a couple days of the oxygenation deficit improving, and also aiming for a negative fluid balance, because this is somebody who, due to the postpartum state and also just being a little bit ill and vomiting, had become fluid overloaded, which I think was part of the precipitant for the aspiration pneumonitis turning into ARDS. So by doing those sort of conservative things well, this is somebody that was able to liberate from the ventilator over about 4 to 5 day period.
That's awesome. That's an awesome case. So let me see if I got this straight. When you have a patient who is having hypoxemia, and we'll avoid the term refractory because we kind of alluded to it, it's really relative to whatever stage you're looking at. But you have someone you're doing high flow on, they're not improving, a limited trial, if no trial at all, of non-invasive, and then moving on to intubating them. Trying to keep the head of the bed elevated all throughout the intubation so that you don't de-recruit. If they're obese, starting with a higher PEEP, I won't say a number, but we'll just say with a higher PEEP right after intubation, going for ideal body weight for tidal bottom ventilation that's based on your height and your gender. If you're still having trouble, they're still refractory, if you will, then the next move might be to do either a recruitment maneuver, or you might go to the bedside, look at the plateau pressures, and then adjust your driving pressure based on that. If you're increasing your PEEP and your driving pressure is decreasing, suggesting that you're actually getting more recruitment, better improvement. After that, the next move might be to consider proning if you're in a center that's comfortable doing it, a team that's able to do it. If not, that might be the decision point to start calling another hospital for transfer. Proning plus or somewhere around the area of doing limited paralysis on the patient. And if you're still having trouble at that point, considering doing inhaled nitric oxide, or a more affordable solution is inhaled prostacyclin for that person. And then ultimately, if you're still having trouble, getting that person on VV ECMO. Does that sum it up?
That's a great summary.
Perfect. Well, that's great, Matt. I really appreciate you taking time to come on and talk through this case. I think a lot of people, especially in this COVID era, which we didn't talk too much about, but when we're talking about the subtype of less compliant lungs of COVID, is this a strategy that you would use for that person, that H type that Gattinoni talks about? Yeah,
I think the H type is probably a little bit more typical of an ARDS like we're used to. I will tell you that whatever phenotype the person is in when they're on the ventilator, paying attention to their driving pressure seems like a sound strategy to try to optimize their settings. Because I have people that have X-rays or CTs that look like they would be somebody that would be an H type, but you put them above 10 of PEEP and then they are over distending. So there's a tendency, I think, amongst a lot of us who are seeing so much of this and seeing it as maybe a unique disease, that we're trying new things and trying to think about it in new ways. But the reality is this is probably more like an atypical presentation of a typical disease. So this is more like ARDS that's got some nuance to it rather than being something completely novel. So I think the first things first is to do proper lung protective ventilation, pay attention to your airway pressures, and just do the fundamentals. And either, whether they're an L or an H or some other letter, I think, those are the kind of things that will help push people in the right directions the best, rather than trying to come up with a magic bullet.
Right. So do what you know how to do and just make sure that you're not harming the patient. And I guess that's what we really do in critical care in general, right? All we're really doing is supporting the physiology until the disease process works its way through, or until our therapies get to kick in. That's the way I always thought about critical care.
Yeah, that's how I describe it to everyone. And that's why, a lot of us on Twitter are always talking about how to be a Zentensivist, because it really involves like, what's the least I can do? What's the best way I can not get in the patient's way while I support them and help them get better?
Yeah, perfectly stated. Well, great. On that note, I'm going to thank you for coming on today and being a guest. And I hope to see you again, talk about more cases, and you'll enlighten us more with your Zentensivist mentality.
Sounds great. Thanks, Haney.
I learned a ton of stuff talking to Matt today. That video was chock full of pearls galore. So go ahead and watch this second time just to make sure you got that all down. Don't forget to hit that like button if you enjoyed the video and hit the subscribe bell if you want to see more of our content. Thanks for watching. It's Critical Care Now, and we'll see you next time.